Good day, everyone. Okay, welcome to this online speech. I'm Chunsha Hong, the moderator of this talk. It's our great pleasure to invite Dr. Frank Sciurba to share his outstanding research and knowledge with us. Dr. Sciurba is a professor of medicine and education, director of Emphysema COPD Research Center and the Clinical Pulmonary Physiology Laboratory in the Division of Pulmonary Allergy and Critical Care Medicine in University of Pittsburgh Medical Center. Dr. Sciurba has had continued NIH funding, including a specialized Clinical Center of Research Excellence in COPD Award. So today, Dr. Sciurba will share the topic, update on COPD disease impact and activity impairment. Let's welcome Dr. Sciurba.
Thank you, Dr. Hong.
Okay, so I will share the, okay.
There you go.
Okay. Okay.
There, nice.
Okay.
Okay, so thank you very much. Thank you for the invitation. Thank Dr. Wang for allowing me to speak to your group. Today, I'll talk about general COPD, the diagnosis and the treatment, but also a bit more emphasis on exercise impairment, which contributes significantly to the poor quality of life in these patients. Next slide.
Okay. Oh, so it jumped up. Okay. Let me. Okay.
So yeah, there you go. Okay. Yeah. So next slide, please.
Okay. Do you see
next slide?
Next.
No, that's good. No,
okay.
Back.
Go back. Okay.
Back. Good. So the definition of COPD has changed over the years as our perspective of the disease has changed. We used to call it untreatable chronic condition, and that would not motivate healthcare workers to help take care of these patients if it is untreatable. So now we know that it's very common, it's preventable by limiting exposures, and it is defined as treatable. It is characterized by persistent respiratory symptoms, as opposed to asthma, where the symptoms can be nearly completely reversed. In COPD, you never completely reverse the symptoms. We optimize the patient and deal with the chronic disease. It's incompletely reversible airflow limitation due to both airway tubes as well as alveolar abnormalities, and it's caused by significant exposure. In the United States, 80% is smoking, but around the world, toxic particulates, indoor, poorly ventilated cooking is also a very common exposure. COPD is an umbrella term for progressive lung disease, including emphysema and chronic bronchitis, which can be very different histologically and physiologically, as well as refractory chronic irreversible asthma and certain forms of bronchiectasis. The most common symptoms in COPD early on is shortness of breath with exertion, and then often associated, sometimes independently, with chronic cough, sputum production, and chest tightness. Next slide. Worldwide, COPD is the fourth leading cause of death, affecting known at least almost 400 million people. The prevalence around the world in individuals over 30 years old is over 10% of the world has COPD. The prevalence expected to increase with increasing smoking, particularly in developing countries, and the increasing age of the population. Next slide. The burden and the domains that COPD affect our patients include their symptoms that we discussed, exercise or activity impairment, which can be disproportionate to symptoms, exacerbations or flare-ups resulting in hospitalizations can be a big burden on the system and healthcare providers. The quality of life of the patient, sometimes associated with symptoms, sometimes disproportionate due to different domains. Lung function decline, physiologic measurement can be independent, and then the risk of mortality, and then the cost to the system to provide the health care to these patients can be a burden on the system. Next slide. COPD is also, and these are data from the United States, but also I think relevant everywhere. It is in the United States the third leading cause of readmission to the hospital. So within 30 days of being discharged from the hospital, over 22% of patients come back and are readmitted. And this is a big concern of insurers in the United States to try and find ways to get people to stay out of the hospital and optimize the care. Next slide. So, that's good. So
this one, right?
Yes, that's good. So the chain of events in COPD initiates with the risk factors and the exposure. And as we said, smoking is a very common exposure, but also exposure to pollutants and particulates, diesel fuel burning from trucks, indoor cooking particulates can cause the disease. But also it's dependent on host factors. We know there's a significant genetic component. Some people can smoke till they're 90 years old and don't get it. Others will get it in their 50s, and it's very family linked as well. With increasing age, the risk goes up. Women are more predisposed. And then there's issues even early on in life with lung development that can lead to changes as individuals age. We know that poor socioeconomic status, a history of asthma, and recurrent infections can facilitate the development of COPD. The disease is probably related to multiple dimensions. The slide disappeared. Can you still see the slide, Chingsha?
No.
I can't see.
Okay. Yeah, okay. Oh, so let me try it again. Okay.
Okay. Next. Oh. And go back. Back. Whoops. Back. 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 One more. There we go. Okay. We'll get through this. The pathogenesis is multidimensional, often initially with the tobacco smoke, but then there's an ongoing inflammatory response in many individuals. And this can be initiated with the oxidative stress, both of the tobacco smoke exposure as well as ongoing inflammation and then often colonization with bacteria in some cases. The proteases released by neutrophils can destroy matrix, resulting in emphysema, but the ongoing inflammatory response can also result in scarring and fibrosis in the airways. Both can lead to obstruction in airflow. And then the downstream physiologic effects, initially we say obstruction to airflow, so people cannot exhale forcibly. But because of prolonged expiratory time, they now cannot inhale because they can't get the air out. They're more limited at the top of their lungs. So there's air trapping. They cannot exhale completely. And then because of destruction in the alveolar capillary interface, gas exchange, oxygen, and eventually carbon dioxide elimination are affected as well. So people's oxygen levels drop with exertion. And this can be disproportionate and independent of the lung mechanical obstruction to airflow. And then other symptoms may be completely independent: cough and mucus hypersecretion, flare-ups or exacerbations, which can be a burden, may be independent of the other factors. And then important to this discussion, all of this can lead to inactivity, deconditioning, exercise intolerance, and further inactivity. Also, as the disease progresses, there can be destruction of capillaries leading to right heart dysfunction and pulmonary hypertension. And finally, often COPD, with that inflammatory response, we get a systemic inflammatory response that can lead to comorbidities, including cardiac disease, disproportionate in patients with COPD, osteoporosis, diabetes, and other metabolic syndrome conditions are associated independently with COPD. Next slide, please. I'll talk a bit more about the exercise impairment in COPD. Next slide. So the left panel is a normal ventilation with exercise response. The yellow area is the alveolar ventilation that effectively removes CO2 from the bloodstream and allows oxygenation. And the red area is the dead space ventilation. That's air that doesn't really get exposed to capillaries and goes in and out. That's wasted ventilation, but mechanically we still have to move that air, both the yellow effective alveolar ventilation and the dead space ventilation. But in normal individuals, we're limited by our ability to deliver oxygen and utilize oxygen. And so patients reach a maximal oxygen consumption, which limits their exercise prior to ever reaching a limit in their ventilation. So normal individuals are not limited by their ventilation. We often have a big ventilatory reserve at the end of exercise in a normal situation. However, several things happen in patients with COPD. We still need the same amount of alveolar ventilation to remove CO2 at any given level of work in the yellow. But the dead space ventilation, the wasted ventilation, is significantly higher. So for any given level of work, we have to breathe more. And then our maximal level of ventilation is decreased because, as we said, there's obstruction to airflow, there's air trapping, and our maximum ability to move air is decreased. So the two factors, increasing ventilation at any given workload and a lower limit to maximal ventilation, results in exercise impairment at a much lower level than in normals. And finally, these individuals are often, as we discussed, very deconditioned, may have pulmonary hypertension, limiting oxygen delivery, and may have synchronous comorbidities with cardiac disease and have a very early lactate threshold. So when we reach our lactate threshold early, it drives minute ventilation even earlier, and then we reach our maximal ventilation earlier. So all of these factors limit maximal exercise tolerance at a much earlier level in COPD and are associated, obviously, with shortness of breath at lower levels of exertion. Next slide. This shows you the hyperinflation that occurs in COPD because they cannot exhale completely. On the left side, you see even at rest, the gray is a normal individual in tidal breathing, in, out, in, out. In COPD, you breathe more toward the top of your lungs. So if you were to take a deep breath to your top of your lungs and now just let out a teacup of air, and then breathe back up from there without exhaling to your normal relaxation. And try and breathe up there and continue to breathe. It's very uncomfortable, and that's the mechanical effects of breathing at elevated lung volumes. Now, in the middle, as patients increase their exertion, normal individuals, the gray, they can exhale more completely because they have good expiratory flow. And so they increase their tidal volume both by exhaling further and inhaling further. Whereas in COPD, they have limited time to exhale, so they don't get all their air out before they take their next breath in, and they get what's called dynamic air trapping. And so they get closer and closer to their full inspiration as they're trying to breathe, and it can be very uncomfortable, accelerating the effects that we see at rest with hyperinflation. So this is this complicated impact of exercise intolerance in COPD related to air trapping. Next slide, please. And this is a little bit more complicated diagram for those of you interested in pulmonary physiology. The dotted line or the dashed line is a maximum flow volume loop. So the flow at any given lung volume, and in expiration on top and then inspiration. And then this is a normal individual. You could see the tidal volume loops at rest, and then the loops get bigger and bigger with exertion, but only at very high levels of exertion do you reach the maximum ability for expiratory flow. So you can increase the flow as you're exercising to shorten the expiratory time and to exhale more completely. Whereas the right panel is a patient with COPD. And you can see that because the flow volume loop is much more shallow at higher lung volumes, the only way that they can exhale completely, because they reach the limit of that flow volume loop, is to breathe at higher lung volumes. And so this is the reason why they developed the air trapping. Next slide. So the other factor that happens in COPD, and we already touched on this, is that for a given level of alveolar ventilation, they have more dead space ventilation. So a normal dead space ventilation is less than 20% of minute ventilation, closer to 0.1. And with COPD, it's not uncommon to have 35% or even 50% of ventilation being dead space ventilation. So they have to breathe more for any given level of effective alveolar ventilation. Next slide. And then another factor is deconditioning, or even further, myopathy. And this panel on the right is a patient who's had long-term COPD, and you can see the muscle atrophy that's developed over time compared to the left panel is a more normal individual. And this then would then lead to earlier onset of lactic acidosis with exercise, which will independently drive minute ventilation to higher levels for any given level of workload. Next slide. And this is represented by when reaching the lactate threshold, increasing because of buffering of bicarbonate with the lactic acidosis. It independently generates additional carbon dioxide, resulting then in a greater burden for more minute ventilation. Next slide. And this is a very interesting article that is worth looking at. Jones in the New England Journal in the year 2000, and it shows Borg scores, leg effort on the top two panels and shortness of breath effort on the bottom panels. Looking at normal individuals, the open squares versus those with respiratory disorders, the top left panel showing that if you're weak and have muscle atrophy and decreased strength, that you have greater symptoms, particularly if you have a respiratory disorder. But even normal individuals who are weak and exercise will have more leg effort and shortness of breath than individuals who are stronger and better conditioned. And this effect, even with leg effort, is much greater in patients with respiratory disease than in the right panel, those with cardiac disease. You can see that weakness it has an even greater impact in individuals who have respiratory disease than individuals with cardiac disease, resulting in exercise impairment. So being deconditioned and having myopathy and respiratory disease is a bad combination for developing both shortness of breath as well as peripheral fatigue. Next slide. And this represents the concept of the inactivity dyspnea spiral. So an individual who has shortness of breath doesn't want to feel uncomfortable. So they stay at home. They sit and watch television instead of going out and walking and exercise. And now they get more deconditioned. And so they now have earlier lactic acidosis, even more shortness of breath. It causes them to pull back even more and abstain from exercise, and they get more deconditioned and more short of breath, and we have this vicious spiral. And that's why pulmonary rehabilitation and exercise training is critical to break this dyspnea spiral, this ever decreasing functional performance in our patients with increasing shortness of breath and deconditioning. Next slide. And finally, the fact that often these patients also have comorbidities, including anxiety, depression, which limits activity, cardiovascular disease, peripheral myopathy, diabetes, other conditions that can impair exercise impairment. And we have to take those into account when we're understanding why they have activity intolerance and in helping them to recover. Next slide. This shows the higher prevalence of comorbidities in patients with COPD, even higher than other smokers, probably because of a systems effect of the chronic inflammation resulting in other vascular disease or matrix depletion in other organs that is linked with the pathology in COPD and emphysema. Next slide. So in order to treat COPD, we first need to know that they have COPD. And so we need to make the diagnosis. And the diagnosis of COPD is initially made through spirometry. And it's a relatively simple maneuver. Patients take a deep breath in and they blow out hard and forcefully. We measure the amount of air that comes out in the first second, and that's called FEV1. And we measure the total air that comes out, and that's called the forced vital capacity. And the ratio of FEV1 to FVC is the FEV1-FVC ratio. When that is less than 0.7, that's the most common definition, and by the GOLD criteria, defining obstruction. So if they blow forcefully, they get less than 70% of their air out, that constitutes a diagnosis of COPD. Who should we do spirometry in? Well, anybody with symptoms and any risk of exposure warrants getting spirometry to make the diagnosis of the disease. Next slide. Another reason to make the diagnosis is to, if somebody still has exposures, to try and intervene. And sometimes showing them that they have obstruction can help motivate them to quit smoking. And these are data from the lung health study showing that, in fact, quitting smoking can slow the rate of decline in lung function considerably and prevent patients from developing worse or more symptomatic disease. Next slide. The GOLD criteria is the most common guidelines and classification of COPD, and they rate it both on the severity of obstruction as well as symptoms, which we'll show you in a bit. But the severity of obstruction is rated from gold 1 to gold 4. Gold 1 being, in all these patients, again, defining the disease by having a ratio of less than 0.7, but then the severity is just defined by the reduction in FEV1, how much they blow out in that first second, as a percentage of predicted based on age, height, and gender. And so patients who have gold 1 disease are still have more than 80% of their FEV1, but they still have a low ratio. Gold 2, 50 to 80% of predicted. Gold 3, 30 to 50, and very severe COPD, less than 30% of predicted FEV1. But remember, spirometry only shows one domain of the disease. These patients can still have cough, sputum production, other comorbidities, and impact of the disease that can be disproportionate to obstruction. Next slide. And also, interestingly, the rate of decline in lung function over time can have many different patterns. And of interest recently is that black line showing individuals that start very low, maybe from childhood exposures or genetics, that they have a less drop in order to develop disease. And so early life events have become a great interest in researchers recently to understand, because often we'll only measure the lung function of individuals that are in their 50s or 60s, and we don't really know where they came from or the early life events that resulted in the disease. Next slide. But even individuals who have COPD, they have very a significant variation in the rate of decline in lung function over time. You can see that the majority of individuals do have ongoing decline, but to the right, there's individuals that over 1 to 2 years have had very little decline in lung function. So it's hard to predict any individual how they will progress in their lung function decline over time. And we need to develop biomarkers that we can measure that say you're going to be a patient that has 150 or 200 cc your decline to the left of this panel versus somebody who has less of a decline, particularly as we develop disease modifying biologics, etc., that can be very expensive to prevent further decline. We wouldn't want to give it to patients that are not having ongoing decline. Next slide. And this is the other scale rating COPD severity based on GOLD A, B, C, and D. And this uses, instead of spirometry and FEV1, it uses a symptom scale, either the MRC dyspnea scale or the COPD assessment test, the CAT. And there are patients that are more symptomatic to the right, B and D, or based on exacerbations, having at least 2 outpatient exacerbations or 1 hospitalization puts you in the CD category. So the most symptomatic patients with exacerbations are GOLD D patients. Next slide. Now, patients with worsening obstruction, the GOLD 4s, are more likely to have exacerbations, but still, many of these patients don't have frequent exacerbations. However, even GOLD 2 patients, while they're less likely to have exacerbations, still, some of the patients, nearly 20%, can have frequent exacerbations or even hospitalizations. So the severity of obstruction, while there is some association with risk of exacerbation, they can be very independent of each other. So next slide. So how about treatment of COPD? First, I'll talk about general guideline-based treatment, and then the development more recently of more specific precision-based therapy that will hopefully improve over the years. Next slide. So the goals of treating COPD, can be to treat the different domains of the disease, treating symptoms, exercise and activity impairment, improving exacerbations, reducing exacerbations, improving quality of life, and decreasing the cost of treatment. All these things have been shown to be impacted by current guideline-based therapy. Next slide, or next. But we have been less effective in reducing mortality or decline in lung function, and more studies are necessary, and more effective therapies are going to need to be developed to affect these important outcomes. Next slide. So first we'll start with non-pharmacologic therapy, and obviously if individuals are still exposed or continue to smoke, we need to try and get them to quit smoking or focus on decreasing their exposures. Influenza vaccination is important in decreasing exacerbations and events, and pneumococcal vaccination has been shown to improve outcomes. Recently, the development of pneumococcal conjugated vaccination with now up to 20 valents is recently our CDC guidelines recommending this as a primary treatment for patients with COPD. In the past, we gave both the PCV13, the conjugated, as well as the pneumococcal polysaccharide, which had more valents treated. But I think that the evolution to the greater number of valents in the conjugated vaccination or conjugated vaccine is going to be the most effective way to vaccinate our patients moving forward. Avoiding indoor and outdoor pollution and occupational risks is important. And then, of course, to the interest of this group, encouraging physical activity and exercise training is really the strongest way to improve symptoms in our patients, even more effective than drug therapies. But the patients have to do the work as opposed to just taking an inhaler. Next slide. The drugs in COPD, the classes have not changed over the years, although the drugs have become more effective because they're longer acting and somewhat stronger. The three main classes of drugs used to treat COPD are the bronchodilators, and all patients with known COPD should be on long-acting maintenance bronchodilators, both the long-acting muscarinic antagonists, and there's now many varieties, starting with tiotropium, aclidinium, umeclidinium, and the beta agonists, which there are also many. But the combination in patients who are symptomatic almost always would need the combination of the anticholinergic and the beta agonists. And then in many patients, we also add an inhaled corticosteroid. And so the triple therapy in many patients is the inhaled corticosteroid and the dual long-acting bronchodilator as maintenance therapy. But as we'll show you, inhaled corticosteroids should not be given to everybody, and many patients don't benefit, and we'll show you how actually blood eosinophil levels may be a guide as to who will be most benefited by inhaled corticosteroids. Other more recent therapies in a small proportion of patients who have persistent exacerbations, including PDE4 inhibitors or roflumilast, or in some patients, regular use of azithromycin, both as an anti-inflammatory and antibiotic, can help prevent exacerbations in some individuals. And of course, oral steroids in some patients to treat exacerbations, but very few patients may need to be on low-dose chronic steroids. We should avoid this at all costs because of the side effects of oral steroids, but some of our patients, we have a hard time avoiding that. Next slide. I'd like to discuss our guidelines we published in JAMA, which are very similar to the GOLD guidelines with some minor exceptions. This was a couple years ago in JAMA. We presented a review of the field. Next slide. Next. Okay, so first, short-acting inhalers, both beta agonists and muscarinic antagonists, can improve short-term symptoms, but they should never be used for the long-term treatment of patients with fixed obstruction. They're known to result in short-term improvement in FEV1, but they've never been shown to improve long-term quality of life or reduce exacerbation risks. So in order to do this, we need to use the longer acting inhalers. And next. And so muscarinic antagonists versus placebo, again, show improvement in lung function, but also with this more durable effect of the longer acting inhaler, also result in decrease St. George Respiratory Questionnaire, SGRQ, which is a quality of life scale. And so that's improved. When the lower the score, the better they feel. And then also decreasing exacerbation risk. Next. Beta agonists also independently can improve lung function, quality of life, and exacerbation risks. Although as an individual drug, the anticholinergics are probably a bit more effective. But if you look at next, yep, good. No, back. Yes. If you look at the combination of anticholinergic and beta agonists versus placebo, they are better than any of the individual drugs alone. Can versus placebo reduce exacerbation rates by 34%, significantly increase quality of life, and have a greater effect on lung function. So this is why, really, since most patients with COPD are never asymptomatic, almost always in symptomatic patients, we need to have the long-acting combination anticholinergic beta agonist. Next slide. There's many different combination drugs, and so if you ask which one should I use, it's not an easy answer because different patients may benefit from different combinations. So ideally, although this is dependent on your formulary, to have more than one choice gives you options. This slide shows comparing two different combination therapies, imeclidinium vilanterol and tiotropium olodaterol, in a crossover study. Granted, more than 50% do better with the imeclidinium vilanterol, but still 20% actually do better with the tiotropium olodaterol. And so these individuals who do better with the one drug don't really care that on an overall average, the other drug may be better because individuals may benefit with one or the other, and it's good to have choices. Some of this may be device related, as we'll show you, and not just the drug. Next slide. Next. And so some individuals actually benefit more by adding an inhaled corticosteroid. And if we look at the effect of adding a corticosteroid in all comers, these patients have a further reduction in exacerbation rate versus just the bronchodilator without the inhaled steroid. Next slide, or next. And, you know, again, reduction in exacerbation rate by 22% by adding the inhaled corticosteroid to the long-acting LAMA-LABA. I'm going to show you that this is, even though on average that's the case, that we can select individuals who may have even greater benefit. Next slide. And this shows the PDE4 inhibitors and that on top of the maintenance inhalers can add a further reduction in exacerbation rate for those particularly problematic patients that continue to have exacerbations. Next slide. So this shows the effect of looking at peripheral blood eosinophil level in guiding inhaled corticosteroid therapy. And so even though overall adding inhaled corticosteroids reduce exacerbation rate, the fact is patients with less than 100 eosinophils have actually very little benefit. You could see in the left panel that in a meta-analysis comparing budesonide formoterol, the inhaled corticosteroid plus the bronchodilator, to formoterol alone, that only in patients with higher eosinophil levels are exacerbation rates reduced by adding the inhaled corticosteroid. And in the right panel, you can see individuals with less than 150 eosinophils do not do better by being on an inhaled corticosteroid than on the bronchodilators alone with regards to exacerbation rate. But in the right panel, individuals with more than 150 eosinophils actually have a significantly lower exacerbation rate by being on one of the inhaled corticosteroid preparations. So we use in eosinophils not as an absolute indicator, but as one other factor to make a decision as to who we add the inhaled corticosteroid to the long-acting bronchodilators. Next slide. And why do we care about whether, we have to decide who gets the ICS? Why don't we just give everybody the triple? Well, the reason is that by adding inhaled corticosteroid, there's actually a couple percent, 2 to 3% incidence of pneumonia per year by adding the inhaled corticosteroid. So it does slightly increase risk of pneumonia. And in those individuals that don't benefit, then why should we increase this risk? Next slide. And this comes from our article just reviewing everything that I just mentioned. And if you're interested, you could pull this article. And I think this is a nice table summarizing an algorithm to approach treatment in COPD. Next slide. So we need to consider not just the drugs, but the inhaler. Next. So error rates with meter dose inhaler can be up to 80% of patients that are not properly trained to use their inhaler. And while the error rate is also high with dry powder inhalers, this is inspiratory breath activated, and the error rate is lower than with the MDI. Next. However, some patients cannot activate the dry powder inhalers. There needs to be an adequate minimum inspiratory flow rate in order to pop the little packets that deliver the drug. And so some individuals do not have, with more severe lung disease, sufficient inspiratory flow rates to activate. It may be between 10 and 20%. And that's why some patients may do better with soft mist or meter dose inhalers compared to the dry powder inhalers. Next slide. Next. So why is it important? Well, patients who do not adhere to the therapy or don't use the inhalers properly are more likely to have hospitalizations and exacerbation rates than those that use or deliver the medication most effectively. So if the medicine doesn't get to the lungs, no matter how good the drug is, they're not going to have the benefit. Next slide. We use a little device in our clinic called the InCheck device that can measure the inspiratory flow rate, and you can set it to the type of inhaler or the inspiratory resistance on that inhaler. And what was found in this study is that 20% of patients were not able to achieve the minimal inspiratory flow rate of 60 liters per minute to activate the dry powder inhalers. And this was more common in women, in elderly individuals, and in very short or lower stature individuals, and especially those with poor lung function. And so we often do measure the inspiratory flow rates to confirm that patients can activate the dry powder inhalers. Next slide. And of course, pulmonary rehabilitation is critical in treating all of our patients with COPD to optimize their activity and exercise performance and minimize their symptoms. Next slide. This was a study done by Dr. Casabiri now 30 years ago, where he showed that significant exercise training can actually decrease the lactic acid production, and this is directly associated with decreasing minute ventilation. And while pulmonary rehab can have many effects beyond formal muscular conditioning, this is certainly one of the potential benefits of exercise training. Next slide. I use this slide to show that there may be multiple multidimensional effects of exercise training in these patients. If we increase the efficiency of exercise, they'll decrease CO2 production, and therefore they'll be able to have reduced minute ventilation for any given level of workload, and will delay the time that it takes for them to reach their maximum ventilation. And also, a project that Dr. Hung has been working on in our lab, it's never been proven, but we believe that it is true. And a little spoiler, Dr. Hung may be proving it, that it decreases central respiratory drive in some patients and therefore can independently reduce minute ventilation in individuals, allowing them lower minute ventilation for any workload and to workload at a much higher level. So multiple factors can be affected by exercise training in our patients with COPD. Next slide. So recent advances in pulmonary rehabilitation include the importance of upper limb training, exercise training. Often intolerance to upper extremity activities is a big part of COPD because they often use the accessory muscles of respiration, which are also used in upper extremity work to breathe at higher levels. And so to train them to both do arm work and to be able to use these muscles to breathe can be very important. Exercise can reduce the symptoms of anxiety and depression in some individuals, which can be very important and is very bothersome in many of our patients. You do not need advanced COPD as an indication for pulmonary rehab and exercise, and it can improve function, as I said, breaking that dyspnea spiral, even in patients with more mild disease. And COPD after a hospitalization or pulmonary rehab after a hospitalization can be initiated very early. Often these patients are uncomfortable, but starting pulmonary rehab can prevent hospital readmissions and promote recovery. It's even gotten to the point where doing exercise while they're in the hospital being treated for an exacerbation, although patients don't necessarily love doing that, it can actually facilitate long-term recovery. And then finally, because there's not sufficient rehab facilities to do training in all of our patients, we've been developing telemetry or telemonitored home-based exercise training, which is increasingly, especially during the pandemic, has been performed in the United States and around the world very effectively. Next slide. So we've talked about now what should be done in all patients with COPD in guideline-based therapy, but there's an evolution now of more focused precision therapy. Next slide. So this would be just a group of all individuals and what assessing their response to an intervention in a clinical trial. Traditionally, next, yes. So you can see that, all the dots moved. You don't really see individually, but the average moved up, and we say, okay, this is an effective therapy. But if we were to look more closely, next slide, at individual groups of patients, next, we may see that, in fact, while on average things moved up, that there's individuals, the red dots, that had very effective response, whereas the green dots may have done worse, the white dots had no effect, and the yellow dots may have had only a marginal effect. So we want to find the red dots, the people who are red dots, to effectively treat them, especially with more expensive therapies. Next slide. And we've begun to think about this. These are the COPD Foundation guidelines. I mean, we do have some features like patients treated with oxygen are only patients with low oxygen levels, either at rest or with exertion. Lung reduction surgery or valves, which we'll talk about, should only be given in patients with certain types of emphysema. The roflumilast or azithromycin, only patients with chronic bronchitis or significant exacerbation. So we've begun to start to think about certain traits that would warrant specific therapies, but we need to get better. Next slide. This is the effect of roflumilast in patients who have the features who have chronic bronchitis, low FEV1, and frequent exacerbators, a relatively small subset of those patients. But when we treat that more precise subset, we can get 20% or more reductions in exacerbation rate. Next slide. Also, azithromycin can reduce exacerbation rate, but we found that it is actually not effective in ongoing smokers. It only works in patients that are former smokers, and it seems to be more effective in patients with more moderate disease who have exacerbations rather than at more advanced gold 4 who have much less of a response. And so we consider these features in deciding who we should treat. Next slide. That we know that COPD can be due to many different inflammatory mediators, not always present in all individuals. So if we can find what inflammatory mediator, often whether it's a Th2 or often the traditional IL-5, IL-14 cytokines seen in asthma versus the more traditional Th1 cytokines traditionally associated with COPD, to perhaps more specifically target with monoclonal antibodies treatments specific to that individual patient. We're not smart enough to do this yet, but we're beginning to study this. Next slide. One target or biomarker that has been effective, and we've already talked about, is eosinophils. And it winds up about 1/3 of the patients have elevated eosinophils we already talked about using inhaled corticosteroids, but when that's not effective, some of the other IL-5 or IL-4/13 modulators can be directed. Next slide. This was a slide looking at IL-5 modulation in COPD. And the effect, while there is some effect on reducing exacerbations with mepolizumab, it was not considered sufficient for the FDA to approve the drug. It was about 18 to 20% reduction in exacerbation rate for a very expensive biologic. Next slide. But if we look at the eosinophil level, as the eosinophil levels in these individuals became higher, they had a much more significant response. Individuals with a historic eosinophil level greater than 300 had nearly a 40% reduction in exacerbation rate. So targeting these populations more precisely can allow the drug to be more effective. Next slide. Also, physiologic specific targeting has been used, for instance, in lung volume reduction surgery in individuals with upper lobe dominant severe destruction or emphysema. They can very effectively, by doing surgery to remove that emphysema, benefit. Whereas individuals with more diffuse emphysema or minimal emphysema but obstruction due to airway disease will not benefit from lung reduction surgery. Next slide. And so this is an example of improved quality of life and or decreased mortality rate. And individuals with upper lobe dominant disease, particularly those with low exercise tolerance, have the greatest benefit in reducing events compared to individuals with more diffuse disease. The right panels, that have nearly no benefit from the lung reduction surgery. So we've learned to target who would be most effectively treated. Next slide. And more recently, we've tried to do less invasive approaches to volume reduction, and valves have been approved in the United States and are increasingly used around the world, where we put unidirectional valves, and there's two different types that are available to allow exhalation of the most affected areas of the lung, to allow them to collapse, allowing the better quality lung to expand without doing the surgical approach. And we'll show you some data on that. Other strategies have been tested but are not approved and have been less effective, including sealants, coils, and steam to reduce the emphysema. Next slide. This is a slide showing the effect of lung volume reduction that's highly, with the valves, highly dependent on the heterogeneity. So that right panel where there's significant upper lobe involvement and less in the lower lobe versus the left that's more homogeneous, you can see that individuals with more heterogeneity, greater than 25% difference in the amount of emphysema in the targeted lobe, have significantly greater improvement in FEV1 and 6-minute walk distance than those that are more homogeneous. Next slide. Next slide. We've also shown that the level of fissure completeness, if you're going to put valves in and the fissures are incomplete, the major fissures that separate the lobes, you need complete fissures to allow the lung to collapse. Otherwise, collaterals from the non-targeted lobe will prevent the lobe from collapsing and prevent us from getting an effect. So we now look at CT scans or measure collateral flow in the bronchoscopy lab before we put the valves in. Next slide. And by doing this, we've gotten very effective in identifying the patients. This was the pivotal Liberate trial showing 50% of the patients using this approach had an effective improvement in FEV1. And this was associated with significant improvement in quality of life and 6-minute walk distance in these individuals. So we became much better at precisely targeting individuals with heterogeneous disease, but also with intact fissures to allow the lobes to collapse and result in improvement. Next slide. And finally, other approaches to treat the airway dominant disease have been effective. Electrical bronchial rheoplasty, treating patients with goblet cell hyperplasia, cough, and sputum production, who may even have only moderate airflow or obstruction, has been shown to decrease goblet cell hyperplasia and improve symptoms. And these trials are currently ongoing. And then the last treatment, which is targeted lung denervation of the vagus nerve, where a catheter is put down that results in RFA ablation of the vagus nerve, which runs along the surface of the airways. And this study has been shown to significantly reduce exacerbation rate in the preliminary studies. And now ongoing studies are evaluating these patients to allow more precise treatment. Next slide. So in conclusion, the COPD burden has multiple domains, including mortality, exacerbations, hospitalizations and readmissions, symptoms, and the burden cost on the healthcare system. Existing and emerging treatments are increasingly effective in altering the burden of COPD. Pulmonary rehabilitation is effective in reducing certain physiologic abnormalities leading to exercise intolerance and other outcomes in COPD. Attention to maintenance inhaler device as well as the type of drug and improving adherence is very important. And then precision therapy is emerging, ranging from biological targeting specific molecular pathways as well as devices targeting specific physiologic attributes. Final slide. So I thank you for your attention and for inviting me to speak to you. I know it's very late for you all. You probably want to get to bed. And so thank you very much. I don't know if there's any questions I'd be glad to answer.
Thank you so much for Dr. Sciurba shared his outstanding research. So now we open for Q&A. If anyone has any issue related to this topic want to discuss with Dr. Sciurba?
Okay, how about me asking a new question first? Thanks for the Dr. Sciurba's presentation. And I'd like to ask, because right now we know about all the potential risk factors of the COPD, including the smoking and the air pollution. I'd like to ask Dr. Sciurba, is that according to your opinion, do you think there will be a differences between the smoking caused COPD and the air polluting caused COPD?
Very good question. So what's interesting is there are some studies on imaging quantitative CT analyses that suggest that tobacco-related COPD is more commonly associated with emphysema compared to particulate exposure that is more dominantly airway involvement. And particulate exposure has less emphysema than tobacco related. So that can have very different symptom presentation. So airway dominant would be less likely to desaturate and require supplemental oxygen. And in the precise treatments, it may be treated differently as we get smarter down the line. Very good question.
Thanks for your answering.
Thank you.
Okay,
So here, okay.
can I have a question?
Yes.
Okay, thanks for Dr. Sciurba's wonderful speech. And I'd like to ask about any differences in treatment concern between emphysema type COPD or chronic bronchitis type COPD. Thanks. And my second question is, inactivity is a critical problem in COPD. However, too much exercise may increase mortality rate for COPD patients. So I'd like to ask about the most appropriate exercise prescription or the exercise intervention intensity for COPD patients. Thank you.
Sure. So with regards to the chronic bronchitis versus the emphysema, often there's also overlap where patients will have both. And so, we'd like to say they precisely fall into the categories, but most patients fall along the spectrum between one or the other. I think, as we get smarter in the more precision therapies, we'll get better and better at targeting the individual differences. Right now, the long-acting bronchodilators, there should be no difference and it should be just based on the obstruction. With regards to the inhaled steroids, I would say probably more commonly the chronic bronchitic will be more associated with exacerbations, and elevated eosinophils are often more commonly associated with the airway bronchitic, but that's not absolute. So you have to take it on a case-by-case basis. But the airway targeted or obviously would not be something we would ever target emphysema, and lung reduction surgery or the valves would never target airway disease. So those are differences that have evolved. With regards to exercise, there are no great prospective long-term studies looking at the effect of exercise training on survival. But the propensity medical record reviews have in fact shown that exercise training improves survival long term. It really doesn't decrease survival. And I would say that it's very unusual for exercise to result in harm or mortality in these patients. Unlike cardiac patients, they can have heart attacks with excessive exercise that has to be titrated. it's unusual. And you know, it does take skill to be able to push these people to see at just the right level. But I can tell you, lung patients and pulmonary rehab, they often look much worse than cardiac patients. If a cardiac patient looks as bad as a lung patient, you're probably hurting them. Whereas you have to push lung patients despite their shortness of breath and encourage them that it's safe and that they can do well. And eventually they can do much better and look a lot better when they're exercising. So I would argue we should push them fairly hard. And often we need to start only 5-minute blocks, maybe, then rest 5 minutes, rest 5 minutes, as opposed, and then eventually get them up to 20-minute consecutive or even longer, in order to get them feeling comfortable and feeling confident in their ability to exercise.
Okay, thank you so much. Okay, Professor Tai is the associate professor in the Department of Physical Therapy. Yeah.
Very good. Good question. Yes.
Okay, so is any others? Okay.
Professor Sciurba.
Okay, you can speak.
Okay, I would like to ask about the exercise. So would you recommend the COPD patients to have some resistance exercise, or you will recommend them to do some more endurance exercise? Thank you.
Yeah, I think both are important. And, you know, particularly in more frail patients, it's difficult for them to do endurance exercise if they're very weak and frail. And so, you know, using even TheraBands or low weight exercise, I think is still very important for them to try and regain some of their muscle tone and their strength. Often that's necessary before they're even able to maintain long-term endurance if they're very weak. So I think both are important.
Okay, thank you. So is there any question?
Can I follow it, ask one more not so relevant questions? Okay.
Sure.
So, Dr. Sciurba, I should introduce myself. I am the third-year PhD student from the Allied Health Sciences. So I'd like to ask another question. It's like, because before I was intended to conduct a study that aims to focus on the not COVID-19, sorry, the COPD patients' exercise motivation. We'd like to investigate their motivation to conduct the pulmonary rehabilitation. And do you have any suggestion on this kinds of the topic? Like, what should we focus, or do you think about this topic will be the novel studies to conduct?
So you're asking, how do you improve motivation to get them to comply with exercise training? Is that what your question is?
We wanted to use a psychometric method to discuss the possible factor that affect the COPD patients to conduct the pulmonary exercise, because we know that the literature has reported a low motivation of the COPD patients to participate. So we wanted to discuss their motivation, how to form their motivation to conduct the PR program. Yeah. So do you think any have?
No, I
do you
think
have any?
that's,
Yeah.
yeah. No, I think that's very, very important. And I don't know that there's a lot of work that's done. I mean, there's descriptive understanding, just what you said, that often it's, well, you know, sometimes it's the doctor that, or the healthcare worker that doesn't understand or believe in the therapy that that is a limitation to motivating their patients, and then the patients aren't motivated. Sometimes it's a lack of understanding by the healthcare worker with the patients of what exercise can do for them, and a lack of understanding. You know, we cannot improve lung function with exercise. And so some believe if you can't improve lung function, what's the value? But there's so many other things that it does benefit. And so I think, if I understand what you're saying, to dissect and understand the reasons for the lack of motivation, and then to go to the next level and change those reasons to improve compliance with rehab, I think is a very good thing. Yes.
Okay, thank you.
Okay, thank you. Okay, so is there any others?
Very good audience. Good questions. Thank you.
Thank you. Okay, so if no more question, yeah, we thank Dr. Sciurba's wonderful speech. And
Thank you.
okay, I believe most PhD students here learned a lot, and this talk brighten their research career as well. Okay, so thanks everyone for attending this talk. Okay, have a wonderful day.
Thank you for having me. Thank
Could
you.
we
Thank you.
take a group photo?
Hey, okay.
So could
Okay.
everyone turn on your camera and we take group photo?
Yeah, everyone is beautiful and handsome.
Yeah, I'll count on 3.
Please send me the photo.
Okay, no problem.
3, 2, 1, smile. Okay, let's take another one, okay? 3, 2, 1, smile. Okay, done.
Okay, thanks everyone. Okay,
Thank you.
have a good weekend.
Thank you. You too.
Bye.